The Ewings sarcoma family of tumors usually arise in skeletal sites in children and young people and consist of small round malignant cells that may exhibit varying degrees of neural differentiation. ESFTs are characterized by a rearrangement involving chromosome 22, and 1122 translocation is detectable in more than 95% of cases. The gene rearrangement results in the production of a transcription factor. In the majority, it is the EWS-FL1 transcription. Most ESFT arise in bony sites, 54% are axial and 42% are appendicular as per the European intergroup Ewing studies data. Treatment advances in Ewing sarcoma have been due to the multidisciplinary approach. Earlier results with only surgery or radiotherapy were dismal, with survivals of around 10 to 20%. With the advent of systemic therapy, considering Ewings as a systemic disease, the combination of chemotherapy, surgery, and radiotherapy has given a 5-year survival for localized Ewings of about 65%. So we are now considering tailored treatment strategies according to the risk group in localized disease. Prolonged disease-free survival is achieved by the majority of patients with localized Ewings after treatment with multimodality therapy. Adverse prognostic factors over various trials have been larger initial tumor volume, histologically determined chemotherapy-induced necrosis assessed in the primary specimen. So the high-risk group includes the tumors with poor histological response to chemotherapy and unresected tumors with poor radiological response treated by RT alone. It also includes large volume tumors at presentation. This high-risk group of patients over various trials have usually developed metastasis within 1 year from diagnosis and had only 13% event-free survival, suggesting the need of more intensive chemotherapy. So this is an unmet need, and interventions to improve survival are required in this high-risk group. The rationale for high-dose therapy, Ewing sarcoma, was developed to exploit an alkylating agent dose-response relationship. So several single-arm studies indicated a high-dose chemotherapy effect using historical controls in newly diagnosed metastatic or recurrent Ewings, using various drugs or combinations with or without total body irradiation. So there were 2 national-level non-randomized studies evaluating the role of busulfan melphalan in patients with poor histological response. These suggested its potential benefit compared to historical controls treated with conventional chemotherapy. So in the selected high-risk population in this trial, which was termed as the R2-LOC population, which we'll be talking about further, the primary objective was to evaluate whether high-dose therapy using busulfan melphalan improved event-free survival compared with standard chemotherapy, which was vincristine, dactinomycin, ifosfamide as consolidation. The 2 national trials, one was the Scandinavian sarcoma group trial, which enrolled 300 patients with a median age of 15 years. There were no toxic deaths. The 5-year overall survival and event-free survival was 75% and 69% respectively for patients who received busulfan melphalan followed by autologous stem cell transplant. There was 72% partial response, 72% PR rates for patients treated with high-dose therapy, and only 33% for those who did not receive high-dose therapy. So the conclusion that high-dose therapy added to the VACA-IE regimen is feasible and effective. Selected groups of patients can benefit from high-dose therapy. The other trial was a French study, which was risk-adapted chemotherapy for localized Ewing sarcoma of the bone, the French EW93 study. So 214 patients were enrolled from 1993 to 1999. And here they considered the high risk as tumors with a histological poor response more than 30% and residual or clinical poor response in less than 50% for unresectable tumors. So this also showed that there was a benefit from a consolidation strategy, including busulfan melphalan, and EFS was 45% and 20% respectively. But despite a risk-adapted strategy, histological response to chemotherapy remained the main prognostic factor in resected tumors. And initial tumor volume was the main prognostic factor for unresected tumors. With that background, we come to our current study. So the R2-LOC study population basically represented the second randomization of the localized Ewing sarcoma, which fell in the high-risk group. The trial was an international randomized intention to treat superiority trial, which was controlled by an oversight committee comparing consolidation treatment with BuMel, that is busulfan melphalan, or 7 courses of VAI in a 2 parallel group design. So the components of the Euro Ewing 99 study recruiting all patients with Ewing sarcoma at diagnosis enrolled by 4 cooperative groups: EORTC, DPOH, the French Society of Pediatric Oncology, and the UK Children's Cancer and Leukemia Group. From May 2010, the patients in GPOH were recruited into the same R2-LOC randomized control trial through the Ewings 2008 study. Inclusion criteria: age less than 50 years, enrollment at diagnosis in either Ewing 99 or Ewing 2008 study for newly diagnosed biopsy proven sarcoma. The criteria for high risk considered here were localized disease with due to a poor histological response to induction chemotherapy, that is residual viable cells more than 10% for patients undergoing surgery for induction chemotherapy alone, or a large tumor volume at diagnosis that is more than 200 ml in an unresected or initially resected tumor or resected tumors with preoperative irradiation, or small unresected tumor in the case of poor clinical response to induction chemotherapy, 50% radiological reduction in soft tissue disease component and no medical contraindication. So exclusion criteria were actually later amended. Initially, there was a busulfan-related radiosensitivity in patients who were expected to receive radiotherapy to the spinal cord more than 30 gray. So in the 2004 amendment, these patients were excluded from the trial. And also those patients who were likely to receive more than 45 gray to a large intestinal volume, depending on the disease site. The other exclusion criteria were interval between the date of definitive biopsy and start of chemotherapy of 45 days, and abnormal cardiac function, including a fractional shortening of less than 29% or an ejection fraction of less than 40%, and an abnormal renal function with a GFR of less than 65 ml per minute. This graph shows the criteria used in the study. This EFS according to the criteria used in the study. The top is for tumor volume less than 20 ml and also having less than 10% viable cells. So they had the best event-free survival, and the poorest event-free survival was for the patients with a tumor volume more than 200 ml at presentation, and also those who had residual viable disease more than 10%. So this is the schema for selection of treatment. All patients received VID as induction, that is vincristine, ifosfamide, doxorubicin, and etoposide. And between the third and fourth cycle, peripheral blood cells were harvested for autologous transplant. After 6 cycles, patients were assessed for surgery. If the disease was resectable and there was a good response, they were sent to the R1 randomization arm. This is for the good risk disease, which we will not be discussing further here. And R2 localized disease, which is our study population, which was randomized between 7 cycles of VAI, that is inclusion, actomycin D, and ifosfamide, or one cycle of VAI for sulfamide, followed by autologous transplant. Randomization. The disease, localized disease, we proceed to step 2A. Modality feasible. Surgery. If surgery was not feasible, that if the surgery was feasible,
Arnab, we are not able to, I think so.
Sir, I think he got disconnected.
Gautam or someone can talk to him. I should realize otherwise क्या होता है कई बार पता नहीं चलता वहां बैठे.
Sorry, sir, I think I got disconnected from the session.
Yeah.
May I resume?
Yes, reshare.
Yes. What was the last slide that was visible, sir? Sorry.
2 slides back from here.
2 slides back. Shall I continue from here?
Yes.
This is a graph showing the event-free survival according to the criteria selected for high-risk disease in this study. That was a tumor volume. Those who had a tumor volume less than 200 ml and less than 10% viable cells, volume more than 200 ml and more than 10% residual viable disease, those who had more than 10% residual viable disease had the worst survival. Am I audible now, sir?
Yes, please continue.
This was the schema for enrollment in the trial. All eligible patients received 6 cycles of VIDE as induction, that is vincristine, ifosfamide, doxorubicin, and etoposide. Between cycle 3 and 4, peripheral blood cells were harvested for autologous transplant, and then after the 6th cycle, they were assessed for feasibility of surgery. So those who went in the good risk group, that is the R1 randomization, they went into a separate arm of the trial, and those who fell in the poor risk group, that is R2, they went into a separate arm of the trial, where they were randomized between 7 cycles of VAI, that is vincristine, dactynomycin, and ifosfamide as consolidation, or 1 cycle of VAI followed by busulfan, melphalan, and autologous transplant. So the algorithm for patient selection was first to consider the disease, if it was localized, to consider the feasibility of surgery, and whether they need to be prioritized for surgery. So, and after surgery, according to the response, they were stratified into good response and poor response. And those who fell in the poor response or high risk group were put in the R2 localized arm. So after 6 courses of VIDE plus 1 VAI consolidation, there was an assessment of histological response were applicable, and patients were balanced and stratified according to the cooperative group, age, gender, and local therapy received. That is resection after chemotherapy alone, or with or without post-operative radiotherapy, or only initial surgery, or resection after chemo or radiotherapy alone. Randomization was done using a centralized randomization software, ensuring the concealment of the next patient allocation. So again, coming to resectable localized tumors, after 6 cycles of VIDE, they went ahead with surgery. If there was a good response, then they were randomized to the good risk arm, that is R1, and poor response were put in the R2, that is randomization to R2 log arm, and went for 7 cycles VAI or busulfan melphalan. And for localized tumors which were resectable or unresectable but delayed radiotherapy possible, they were evaluated again. So small tumor volume less than 200 ml went to the good risk arm, that is R1 randomization, and those with tumor volume more than 200 ml at baseline went to R2 localization, R2 localized disease for 7 cycles VAI and busulfan melphalan with or without radiotherapy. So the outcome measures, the primary endpoint was event-free survival, defined as the time from randomization to the date of the first failure assessed by the investigator. And failure was considered as progression, relapse, second malignancy, or death, whatever the cause. And secondary endpoints were overall survival since randomization, considering all deaths, whatever the cause. And chemotherapy toxicities were assessed as per CTCAE version 2, and radiotherapy toxicities assessed as per RTOG classification. Follow-up was done every 3 months during the first 3 years, every 6 months during years 4 and 5, and yearly thereafter, regardless of the treatment compliance. Statistical analysis was designed to ensure 80% power for a 40% reduction in the risk of an event in the busulfan melphalan arm compared with the VAI arm, with an expected 3-year EFS of 70% versus 55%, hazard ratio of 0.6, with a two-sided log-rank test alpha of 0.5. The initial sample size was considered to be 328 patients. Recruitment was stopped because of low accrual, and survival analysis was done by the Kaplan-Meier method. Follow-up estimate was done by the reverse Kaplan-Meier method. Hazard ratio was by Cox regression models. It was a post-hoc analysis using SAS 9.3 software. Coming to the results, this was conducted across 131 centers in 13 countries. Finally, 246 patients were enrolled in the trial, and out of the patients enrolled, 118 went to the VAI arm and 122 went to the busulfan melphalan arm. The median follow-up duration of this trial was 7.8 years. Baseline characteristics, there was a slight male predominance in both arms, and recruiting groups. As per recruiting groups, the patients were contributed from EORTC, UK Children's Group, GPOH, and GPOH, which were later recruited into Ewings 2008. The median follow-up duration, as we can see, was 7.8 years. The primary sites were more in the axial skeleton and slightly more than those in the limbs. And this is the further, so the tumors less of more than 200 ml, 60 were in the VAI arm, 63 were in the busulfan melphalan arm. And according to the histological response, there were 44% patients in the VAI arm who had more than 30% viable cells, And there were 42% patients in the busulfan melphalan arm who had more than 30% viable cells. So these are the survival curves for EFS. The blue curve is for BOOML and the yellow curve is for VI. As we can see, the overall event-free survival 3 years was 62.9% and at 8 years was 54%. The overall OS was 75% and the hazard ratio is 0.63. EFS as per arm for VI at 3 years it was 56.7%. For busulfan melphalan it was 69%. And the benefit in EFS was sustained over 8 years. So at 8 years, it was again 47% for VAI and 60.7% for busulfan melphalan. For OS, the similar results were seen. At 3 years, there was a benefit for busulfan melphalan, that is 78% versus 72%. And the benefit was sustained till 8 years, 64.5% versus 55.6%. This is the effect on the different components which were assessed for event-free survival. And here the p-value was significant only for distant metastasis. So it showed that busulfan melphalan primarily reduced event-free survival by reducing the risk of distant metastasis. These are the curves for the 4 components of event-free survival. As we can see, there is maximum separation in the curves for distant metastasis. These were the deaths which were death as the first event or considered as therapy-related deaths. So this was mentioned in the trial supplement, the reasons for the deaths in these patients. One patient from the busulfan melphalan arm had a death from an acute bronchopneumonia occurring 5 years after the end of treatment. One patient had a cervical tumor with radiation-related myopathy occurring 9 months after treatment end. In the VAI arm, it was not a therapy-related death. And in the busulfan melphalan arm, again, it was an acute respiratory distress syndrome associated with pancytopenia after therapy, 5 months followed by end of treatment. 2 patients who died in the busulfan melphalan arm actually did not receive busulfan melphalan, but they received VAC and VIDE respectively. So this is as per the subgroups. There was no significant heterogeneity of the treatment effect according to the cooperative group, the tumor site, the tumor volume, or eligibility criteria. There was more benefit seen in those who had an intermediate poor response, that is, those who had 10 to 29% viable cells, rather than those who had a poor response, that was more than 30% viable cells histopathologically. And there was a slightly more benefit in older patients, that is, age more than 25 years. So in EFS and OS, there were 105 events reported for EFS, 60 in the VAI arm, 45 in the BOOML arm, 13 local progression and local relapses, 18 distant metastasis, including lung metastasis in 51 patients, 5 secondary malignancies, 2 in the busulfan melphalan arm and 3 in the VAI arm, and 7 deaths as the first event, which we have already covered previously. These are the serious adverse events across both arms. The light yellow is for busulfan melphalan and the darker part of the graph is for the grade 3, grade 4 toxicities. So it was observed that the busulfan melphalan arm was more toxic. There were more severe, particularly GI and hematological toxicities, the most severe being grade 3, grade 4 mucositis and stomatitis in the busulfan melphalan arm, along with grade 4 hematological toxicities. However, with busulfan melphalan, there were single-time toxicities with high-dose chemotherapy, whereas for VAI, they occurred repeatedly with repeated cycles. So coming to the discussion. In this trial, they were considering surrogate of chemo resistance by seeing the response of the tumor to chemotherapy. So the use of the histological response as the main selection criterion identified a population of patients with some degree of initial drug resistance. In the Autologous study, this is supplemented by other high-risk patients who accounted for around 20% of the randomly assigned patients for whom histological response was not available because they underwent surgery prior to chemotherapy. This subset of patients may have included patients who had an unidentifiable good response to induction chemotherapy had they received induction chemotherapy at baseline. Overall, the effect of busulfan melphalan seemed consistent across the main strata, that is across the cooperative group, the tumor site, the tumor volume or eligibility criteria. Within the poor risk spectrum, it is possible that it may have less benefit in those with a very poor response. That was an observation from a post-hoc exploratory analysis. There may be less benefit for older patients, though this observation may be by chance, and the test for interaction was not significant. There is an interaction of busulfan melphalan with radiotherapy. It was chosen as a high-dose therapy based on an international transplant registry data and previous work by the French Society of Pediatric Oncology. However, there were concerns with interaction with radiotherapy with radiosensitization, including a fatal toxicity, which led to a protocol amendment. So there is a little evidence to define thresholds for concurrent use of radiotherapy and busulfan. So one of the main benefits was seen in the reduction in lung metastasis. This was one of the main areas where the effect of high dose therapy was seen. We cannot exclude that whole lung irradiation given instead of high dose therapy will have similar benefit. In the toxicity profile, as expected, more patients experienced severe toxicity in the busulfan melphalan arm than the VAI arm, mainly hematological, digestive, and hepatic. But they were transient toxicities and occurred only once after the busulfan melphalan chemotherapy, compared with repetitive hematological toxicities occurring with each VAI course. Strength of the study: it was a multicentric study with a long duration of follow-up. A randomized study showing the benefit of a risk-adapted strategy for the high-risk localized disease in Ewing sarcoma and unmet need in this disease population. In the weaknesses, the recruitment fell short of the recruitment rate proposed at the study initiation. There was an absence of a central imaging review for tumor volume and response, and pathological reviews were not undertaken. There was a benefit shown for busulfan melphalan versus wide, but not versus other regimens. And the radiosensitizer effect of busulfan limits its use in patients who will require radiation over a large volume. A large number of patients who fall in the high-risk group may require a large volume radiation to the residual disease. So the use of busulfan in this population then becomes challenging. This is another approach to dose escalation, which is a randomized controlled trial of interval compressed chemotherapy for localized Ewing sarcoma from the Children's Oncology Group in the USA. And this is an alternative strategy to dose escalation, where rather than increasing the dose, we decrease the time interval and provide interval compressed chemotherapy. So in the intensified arm, again, there was an EFS of 5 years, 73% EFS at 5 years, which is also a good benefit. In conclusion, busulfan melphalan may be considered as an option for patients with localized Ewing sarcoma fulfilling the definition of high-risk disease in this trial and having no contraindications. And the opportunity this trial gives us is through a head-to-head comparison between the regimens used in this trial and other effective regimens for Ewing sarcoma. This is a currently ongoing trial, that is the Euro-Ewing 2012 protocol, which is an international randomized controlled trial for the treatment of newly diagnosed Ewing sarcoma family of tumors. And this has 2 trial arms exploring both strategies, which is VID as well as the dose compressed VSCI from the COG protocol. And again, the good risk disease will be randomized to consolidation with standard chemotherapy or consolidation with high-dose chemotherapy and autologous stem cell transplant. The results of this trial are still awaited. Thank you.
So thank you, Arnav. So just summarize, in which patients you will select and consider bumal consolidation?
Sorry, sir, I was not able to hear your question clearly, sir.
Yeah, just summarize which patients you will select for bumal consolidation.
The patients who had either a poor response to induction chemotherapy, that is residual viable tumor more than 10%, or those who had a high volume disease more than 200 ml at baseline, they may have been operated upfront or may have received radiotherapy upfront also. So then we may not be able to judge the histological response. So these were the 2 criteria used for high risk disease in this trial.
Okay, and which will exclude? There was an important exclusion criteria also which you discussed.
Yes, sir. That is those who are likely to receive large volume radiation near the spine or to the lungs. Sorry, to the spine or to the bowel because of the radiosensitizing effect of busulfan melphalan. So those were excluded from this trial.
No. So our BMT team is also here, and also as always Kumar sir is here. So Kumar, would you like to take up the discussion?
Any other question by anyone or comment? I can see Dr. Naveen here and Dr. Sumit here.
Arnav, can I ask a question?
Go ahead.
What was the number of patients or percentage of patients who failed to mobilize stem cells in the stem cell transplant arm or in the between cycle 3 and cycle 4?
I'll just answer this way.
Yes, the perspective from a transplant team is also important to understand. So here we wish to know how many patients were able to be mobilized and what percent patients failed to be mobilized, because these patients are receiving intensive chemotherapy. Arnab, are you able to hear?
Yes, sir. No, I'm not able to find the numbers, sir. Sorry.
Okay, we'll come to that. Then that is a very important question actually for us.
Akhil,
Yes, sir.
so
Yes, please.
unlikely that there will be failure of mobilization, because 3 cycles or 4 cycles is not too much of chemotherapy. So usually the mobilization failure happens when you give too much of chemotherapy. So my guess would be that most would have been able to mobilize. And I think they've received ifosfamide and etoposide, in that wide.
Yes.
Yes.
So those 2 agents are used for mobilization. So I don't think there'll be more than 5% probably who may have not mobilized, until unless they've received radiation to areas which can harm the stem cells. But as Arnav said, that those who were receiving spinal RT were excluded. So, unlikely that, I think most would have been mobilized for the high-dose therapy.
That's a good news. Naveen sir, any comments from your side on this perspective?
I think this is the largest trial. It took a lot of time, and you have to look at the trial with the effect that it does answer a question to some extent. Now, as Arnav said, if your histological response is poor, that means you have more viable cells after surgery, post the induction chemotherapy. That will also decrease your response to transplant, because the high dose therapy is basically increasing the doses of some of the alkylating agents to a level that it will increase the cell cytotoxicity of cancer cells, but of course not damage all the organs which are important. So I think from what I understand, and this has been discussed earlier also, in patients where the histological response is not very poor, I think the cutoff they gave us 30%. I think if anyone has viability of more than 30-40%, I'm not very sure how much transplant would also help. But I think if it is in between that 10 to 30, I think there is merit in taking patients for high-dose chemotherapy for localized Ewings sarcoma, especially if the volume is also above 200 ml. The volume of 200 ml actually makes it more easy to understand, because just because you have high volume, it doesn't mean that you may not be chemosensitive. So I think, I feel that the volume is very important for the benefit, especially if there is less viable histology that is less than 10%. So probably the best would be volume more than 200 with a histological response with viable histology being less than 10%. I think they will do better even with transplant, for the simple reason that, mostly they'll be more chemo responsive. And of course, the large volume is a adverse prognostic factor. So, I think this trial just gives us the, the way of taking patients for transplant who have high risk localized disease. The radiation probably should be given after the transplant, because once you give radiation before transplant, then the transplant toxicity increases. And that's something which is all across the board. So I think that's one thing we need to keep in mind.
Thank you, sir. Thank you. So these were the very important insights which might help us to consider which patients will be the most suitable one for transplant in our settings. Any other comments? Dr. Prabhat, you want to make a comment?
Okay.
I think Kumar sir.
Akhil,
Yes, sir.
yeah, actually, this study was terminated prematurely, if I'm not wrong. Does it affects the because of a low accrual? Is this the result? Can we take it?
Sir, this we had discussed last time also. If a study has terminated earlier but is still able to prove the statistical significance, that means it is enough powered for that percentage. If that would have been non-inferiority study or anything others, then it would be difficult. But being a superiority design, it is sufficient, sir.
So Amit, can I just come in? I think most important is to look at our own data of, those who are more than 200 ml and those who have poor, histological response. And, what has been the results of chemotherapy, because we've hardly done any transplant for Ewing sarcoma. So you will get to know if the results are poor, then, one has to look at strategies which can improve it. And if, I don't think there'll be any large randomized study to validate this results. So, one has to look at those results and think that probably there is a benefit. So I think maybe Jyoti can answer that question of, what is the long-term survival of those who had 200 ml volume greater and less than 10%, more than 10% viable cells after surgery. I mean, what is the long-term outcome? If the long-term outcome in our center is more than 50%, then, why would anyone want to go for transplant with all its errant logistic issues and toxicity? But if it is 10% or 15%, then certainly it merits to be taken up.
Yes, sir. Our results also remain poor, and these are even the patients with these two combined criteria. I think we have 5-year EFS of only 20%. So exactly, I might not be sure, but definitely these are very poor outcomes as far as I remember from the previous published data from Jyoti ma'am. So this is definitely an area where we need to do something to improve our outcomes if feasible.
Dr. Naveen, any comment regarding the Bumel? Is it the right or thing, or anything could have been better?
So, I think the Bumel comes from the fact that there's a large trial in neuroblastoma where, the Bumel was compared with carboplatin, etoposide, and melphalan. And there was there was more toxicity and less response with that CEM. You have to have 2 alkylating agents or more for any of the diseases in which transplant is done. If you ask me, there wasn't much logic of using the beam also when it was first used way back in late 80s, and it showed that beam was a good conditioning regimen for lymphoma. So Bumel is a good regimen. It increases the risk of VOD. It increases the risk of lung toxicity. Busulfan can be replaced probably by triosulfan, but there will not be any randomized study to compare the two. What we have done is that we've used triosulfan replacing busulfan for neuroblastomas. So we certainly saw less immediate toxicity. But will it affect the long-term cure? I don't know, because neuroblastomas patients, they're not too many, and it's only recently, last 4 years or 5 years, when triosulfan became available, that we started using triosulfan. My guess would be that probably both will be equal. Triosulfan, busulfan belong to the same family of chemotherapeutic agents, and triosulfan certainly has less lung toxicity, less GI toxicity, and less liver toxicity. So, I think if you replace the busulfan with triosulfan, that should be okay. Any other conditioning regimen used, there would be, but they would be far and few. But, Bumel is a standard regimen which is being used in Ewing sarcoma and neuroblastoma.
Okay, sir. So definitely, sir, I had some experience of using triosulfan in our BMT patients when I was under you for a long time. So definitely, we had seen that compared to Bumel, trio had significantly lower toxicity. That was the thing which we learned from you and also seen in our experience during the training. Kumar sir, your comments?
So, Akhil, so it's a nice presentation, Arnav. And from my side, the comment is that it's not easy to have these kind of randomized trials. So, and you have a good follow-up, you have an 8-year follow-up, curve looks good, curve is not erratic, that it has behaved differently at different time points. And you have almost 9 to 10% absolute improvement in survival. Hazard ratio is 0.63. So looks like that the whatever result you have got is in this study, it is valuable. Now the problem with these tumor remains that you have all wonderful chemotherapy first line. You have nothing salvage. So if you are able to add 9 to 10% life to these patients, sure, you need to select appropriately. Then this option needs to be considered in these patients, because once if you give it and they fail later on, you don't have. So we use a whole lot of treatment in these situations. We have those second, third lines, but hardly I have ever seen patients benefiting substantially. So, and in this situation, if you have those 10% absolute improvement in survival, yes, this option needs to be considered in these patients. Yes, choosing those patients, that will be something one needs to be careful about.
Yeah, Kumar is absolutely right. We don't have salvage therapies for these patients, and it's very sad when they relapse, and it's quite a terrible state when they have lung mets, and they're and that's for any cancer patient, to be honest. But Kumar is absolutely right that if there is an improvement, so by selecting the right patients, I think there is merit in doing transplant in these patients. Otherwise, the prognosis is very poor. And as you said, Akhil, that our own data is some 20%, then certainly we must, do something. My only worry becomes if you don't take them at the right time. Suppose you give 6 cycles or 7 cycles of VIE, and when you have this bad wait list, just like in neuroblastoma, these patients, if you don't take them immediately or within a month, then it defeats the purpose. That's the only concern which I feel we have logistically. Otherwise, I don't think I have any doubt in my mind that these patients may benefit from autologous transplant.
These are very important points which we have got from our teachers about selection of the patients, about the unmet need, about the timing and the logistics. All these things play a very important role, and definitely it seems that the consensus is that these patients definitely deserve treatment, better treatment to augment the results, because our results are also poor in these poor risk patients. So we need to consider selecting the patients well remains the key, and the timing also remains the key. Any other comment or anything from anyone, including residents or consultants? If not, Kumar sir, should we close?
Thank you. Nice discussion. Thank you.
Thank you. Bye.